But anyway, so the story actually I'm going to talk about is kind of an older story. It started in 1994 from our laboratory. So I'm kind of like doing a review of what happened, the origin or the genesis of this idea and over the years and how this idea has kind of penetrated into the clinical practice. I'm talking about the little bit of mechanism as well. So I have nothing to disclose. And, so we all know the opioids kind of have multiple functions, if you will, but most of, obviously, we're interested in the analgesic aspect. And opioid also have, for example, addiction properties and side effects, which we don't like. But back 20 years ago, we started some laboratory studies on indicating that opioid may actually produce the effects which is counteractive towards its analgesic effect. So I'm going to tell you that story a little bit. Before I do that, I just want to show you a piece of data we actually created a few years ago from a set of charts from the clinical patients. So the question we asked is very simple. We say, we know these patients over years, they have their opioid dose kind of titrated over years. So in this set, we have over 100-some patients, outpatients, chronic pain patients, and their opioid dose has either increased or decreased. And we want to see whether the opioid dose adjustment has anything to do with the changes in clinical pain score. And so this is what we found. So we have two different groups. One group is, you see they have opioid dose basically increase over years. And some of these patients, each patient is represented in this basically histogram as a column. So you see some of the patients have their opioid dose increased by almost 1,400% over years. And then we look at the pain score, which is represented as, I'm not good at using this mouse, but as the red bar and the change, you can see the the pain score change is very minimum. And this shows that there's a really disconnect between the dose adjustment and the actual pain score adjustment. But the next slide, I think, is very fascinating to me because this is a group of patients, their opioid dose is a decrease over time. And some of them actually tapered off entirely. As you can see, is minus 100%. That means their opioid dose is tapered off. And you look at the pain score change, most of them actually have decreased the pain score over time. And this is obviously, this was done back 2013. But the idea of so-called opioid-induced hyperalgesia, that concept was introduced back in 1994. I'm going to show you in a second from a laboratory study. So this is kind of interesting to see that in the clinical setting, actually we see a group of patients, if you decrease their opioid dose, their pain score actually improves. And there are probably close to a dozen case reports now in the literature showing the same kind of finding. So opioid-induced hyperalgesia, I think every one of you probably heard this. So this slide, seems to me this is like a piece of kind of origin how this idea came from, because this is the slide I made back in 1994. And at that time, we don't have a PowerPoint. This is actually the film, and I copied it back into this. And I want to keep this slide. Why? Because this is really the origin of the, at least I'll explain in a second. I think it's the origin of this idea in the setting of opioid being used as analgesic and in animal studies. So you look at this is actually rats basically being treated with intrathecally with either opioids, in this case is 10 microgram morphine once per day. And this is basically the white dotted line, and you have a blue dotted line over here, rats treated with intrathecal saline as a control. And you can see at the very beginning, their baseline is pretty much the same. And the test we used at the time was a so-called pore withdrawal test. And there's actually subtle difference between pore withdrawal test or therapeutic test. And it's not so much the site where the test is done, but rather the setting in terms of the temperature is rising, the slope of the temperature rising. And before the pulse withdrawal test was introduced into the field, and people typically use Therapeutic test, and the baseline threshold typically was about 4 seconds. So the temperature rises from the neutral temperature all the way to the threshold temperature very fast. But Therapeutic test, as you can see, the baseline is typically at about 11, 12. So that creates a slow rising kind of temperature. That slope slows the slope, the rising, the slow, actually create a subtle kind of changes you can appreciate over here. So you can see the baseline is over here, and 7 days after treatment, on day 8, you can see that there's a huge actual difference in terms of the baseline threshold. So remember, these are the rats, these are naive rats. They only treated with opioids, supposed to be analgesic. And so then we discontinued opioid at this point, and 2 days later, we checked again, and the threshold again is a decrease. Now, this is the indication that these rats, their nociceptive threshold actually is a decrease. That means they are more sensitive to nociceptive stimulation. And this is the origin at the time, actually, we didn't call this as opioid-induced hyperalgesia, because we tested this in the setting of doing opioid tolerance. And this is a little bit of kind of serendipitous finding, because in the past, when people use Therapeutic test with a fast rising temperature, that was not detected, and the pulse withdrawal test actually showing that. Now, that finding published in Journal of Neuroscience back in 1994 was repeated by multiple laboratories using different opioids with different sensory modalities, such as mechanical heat, as we used over here. So the basic finding of chronic opioid exposure in animals can actually lead to decreased nociceptive threshold has been repeatedly proven. But the implication of this finding and how this actually kind of take place within the central nervous system has not been known very well. So I'll show you one slide. Actually, it took us almost 10 years to kind of construct this particular slide. But the idea is that with this finding, we're really talking about two different arms. In the past, when we see opioid doesn't work anymore, we typically blame because the opioid tolerance, which probably is true. But with the idea of so-called opioid-induced hyperalgesia, now we are talking about opioid can actively change the central nervous system, leading to an increased response to nociceptive stimulation. So in other words, the very agent that's supposed to be decrease pain may potentially cause pain. So that, to me, is a very significant finding from the laboratory point of view, but it wasn't kind of penetrating into the clinical area until early 2000. So this is a slide, actually, as I said, it took us almost 10 years to construct. In part is because there are so many pieces come together. And the basic question we asked was, why would the system do this? Opioid, probably the most powerful analgesic we have up to this point. Why would the system do something like this? Not only make the opioid analgesic decrease over time, which is the tolerance aspect, but the system actively actually fighting against this kind of analgesic effect by increasing the response to nociceptive stimulation. That's question number one. Question number two is that how the system does this. Because we know the reason opioid produce analgesia is because opioid can decrease the membrane excitation. And when opioid decrease membrane excitation at the presynaptic site, basically the calcium channel cannot be activated, if you will. Then the neurotransmitter cannot be released effectively, which blocks the nociceptive signal. Makes sense. Postsynaptically, in second-order neurons, same effect. So cell membrane is hyperpolarized. So the pain signal cannot be transmitted. That's the whole point why opioid works in terms of decreased pain. But the other thing we noticed that this whole system actually requires at least in my mind, requires the activation of a receptor. It's called an NMDA receptor, which is a major subgroup receptor of the glutamate receptors. But you all know, NMDA receptor has a very specific feature. So most receptors, they either voltage gated, meaning that when the cell membrane decreases, then the sodium channel opens, then the cell becomes excited. And this receptor is both voltage gated and ligand gated, meaning that simply binding this receptor with glutamate is not going to make this receptor be activated. The cell membrane has to be partially depolarized, becomes less negative in order for this receptor to be activated. So here comes the problem. The problem is that, as I mentioned earlier, opioid hyperpolarize cell membrane, meaning that inhibiting cell membrane excitation. So how could this opioid under this kind of circumstances can lead to the activation of NMDA receptor, therefore lead to the hyperalgesia? So that question was really haunted us for quite a few years until there was a group from Texas, actually they published a paper, I believe it was in Science, not in Nature, in early 90s. And so their finding was that opioid exposure to the cells can actually lead to the upregulation of a protein kinase. It's called a protein kinase C. And the protein kinase does basically one thing, is phosphorate proteins. So in this case, when protein kinase phosphorate the complex over here, basically G protein mu opioid receptor complex, which leads to decreased responsiveness to opioids. That's one of the mechanisms leading to so-called tolerance. Whereas protein kinase C phosphorate NMDA receptor, and I didn't mention that NMDA receptor is coupled with a calcium channel. And within the deep calcium channel site, there's a magnesium blockade. And the protein kinase C phosphorate this NMDA receptor calcium channel complex actually can remove magnesium blockade without the requirement of cell membrane partial depolarization. So that makes it possible that repeated opioid exposure, even though the cell membrane is supposed to be hyperpolarized, you can still see the NMDA receptor is activated. So there are a lot of other kind of things going on during that period, but the point is that this, from the neurological point of view or the neurobiological point of view, the cellular, at the cellular level, this can take place. But I still didn't answer the first question that I raised. I said, why would the system do this? And I think from the biological point of view, I think it makes sense because pain as a defensive system is probably one of the most important defense systems in our kind of body. So when the outside agents or whatever happens to blunt that particular system, I think the system is going to fight back, say, I want to make the system more sensible. So that, to me, makes sense from the biological point of view as well. So that's the animal study or animal story. So what happens in this case, we're really talking about repeated opioid exposure leading to a state or neurological state that is similar to the development of neuropathic pain. So what's the implication in the clinical setting and what the human kind of studies show about this? And I have to admit it though, after 25 years, we still don't have a tool in the clinical setting to differentiate between opioid tolerance and opioid-induced hyperalgesia. In part it's because if we simply use pain score reduction or the requirement of more opioid as the clinical endpoint, there's no way for us to basically differentiate this. And we still don't have a tool, even though I'm going to show you in the human kind of subjects, we can use something called quantitative sensory testing. We could potentially make some differentiation, but it's not a kind of complete, it is not a foolproof. But this is actually the set of data you collect from these studies. So the idea of this set of data is that if you have this so-called opioid addicts, and they obviously are opioids, and then opioid addicts, they also take a methadone as a maintenance kind of program. And you can see the pain sensitivity actually is increased in those patients chronically exposed, or these addicts chronically exposed to opioids. This is actually a set of kind of human data, to me, is quite strong. And this actually is right to our own kind of territory in a way. As anesthesiologists, we use remifentanil. I remember I was a resident towards the middle of 1990s, and anesthesia resident, and remifentanil kind of introduced into the practice. And so one thing we actually all noticed was remifentanil works beautifully, except that you have to somehow prepare these patients before you turn them off. Otherwise, they often have a very tough kind of PACU kind of stay. And at the time, obviously, we think of this because the system is overwhelmingly exposed with remifentanil. But this actually becomes one of the most reliable human model or human kind of like findings in terms of opioid-induced hyperalgesia. So if you use intraoperatively with remifentanil, you can find post-operatively, these patients, not only they use more opioids, but they also complain of more pain. So this is another piece of kind of evidence. The other piece of evidence, as I mentioned earlier, was so-called quantitative sensory testing. And there are different ways to test that. So in this case, what we found was that this is kind of naive group. They have no pain, not on opioids. This is chronic pain group, but not on opioids. This is chronic pain group, and with chronic opioid exposure at the level of somewhere between 50 to 100 milligrams daily dose, and for more than at least 3 months. So this is what we found, that in this group of patients, their pain score actually, their temperature, pain threshold temperature was decreased by about a 1.8 degree. And it doesn't seem a lot, but this is because human subjects actually typically, our response to heat pain stimulation is relatively homogeneous. And the range is very small, and typically will be somewhere between 43, 44 to 46-ish. So to have seen this group of patients, chronic pain patients on chronic opioids, have a decreased heat pain threshold, reminiscent of what we found in animals, actually is quite a kind of confirming to me. So I'm going to skip this. This is basically exacerbated temporal summation, another kind of indicator of what's happening with these patients. And I have 7 more minutes, and I want to get into the kind of like a link this idea with the next 2 talks, why we want to kind of introduce not necessarily opioid-free, which probably is more like a slogan, because in the actual clinical practice that may not be possible, but at least trying a way to decrease opioid use in intraoperative and perioperative period. The reason is very simple. You look at this kind of flow chart, because in the past, opioid exposure leading to the cellular changes I talked about, and there are at least 5 different kind of ways to explain why opioid tolerance can take place. So we're not going to talk about that, but the point is that because that kind of cellular mechanism can lead to so-called pharmacological opioid tolerance. So how do we clinically overcome pharmacological opioid tolerance? We increase the opioid dose. And that has been done for decades. But with the concept of opioid-induced hyperalgesia, that concept or that practice really needs to be challenged. Why it needs to be changed? Because every time you increase opioid dose, you may potentially add more fuel into this arm, leading to so-called opioid-induced hyperalgesia. But in the clinical setting, what I typically call is so-called apparent opioid tolerance. So in the clinical setting, this is why I feel at this point, we still kind of like powerless in a way. We cannot differentiate opioid tolerance and opioid-induced hyperalgesia in the clinical setting, because so-called apparent opioid tolerance. Why? That means the same dose of opioid can no longer produce the same degree of analgesia. Or in order to maintain the same degree of analgesia, you have to increase opioid. That's what we see in the clinical setting. However, this concept, I hope, will change the way we look at the opioid, its efficacy and its long-term usefulness. Besides the addiction aspect is a separate aspect in my view. And not every patient ends up with addiction, but I've seen patients with short-term exposure, even with opioids, in 70s, and they end up they just depend on opioids. They cannot get off opioids. That's a separate story. But what I'm trying to say is that what we're saying is with opioid-induced hyperalgesia, there's a possibility that what we're supposed to be doing good to our patients end up actually doing harm to our patients. That's the part I was trying to get to that. And so the way to solve this problem at this point, while we cannot, or we don't have a tool specifically to differentiate in the clinical setting between opioid tolerance and opioid-induced hyperalgesia. So one way to do that, from the perioperative point of view, you want to minimize opioid use. And I was in a session yesterday talking about whether intrathecal or the epidural, for example, opioid use is a good thing. And that question was actually raised almost 20 years ago. In my view, given this kind of underlying the cellular mechanism, I think adding more opioids into the neurexia route probably is not the best way to do it. And I do have this slide. This is kind of like a summary. We cannot completely differentiate or effectively differentiate between opioid tolerance and opioid-induced hyperalgesia. At least we should try it. And the hallmark of this, to me, is that if you see a scenario that repeated opioid dose escalation no longer leads to the outcome you are expecting, and maybe the next move you're going to make is not necessarily adding more opioids, but trying to decrease it. And from the research point of view, quantitative sensory testing is probably more indicative than the clinical kind of judgment. But we cannot do quantitative sensory testing on every one of our patients, and obviously we cannot do it intraoperatively while we put a patient to sleep. So that's the problem we are facing. Now, so I don't know how many of you actually doing the outpatient management. This is because one of the things you see the opioid use in the clinical setting, the pendulum has been swung back and forth. And in my short kind of, period of practicing, which is close to 30 years now, 20-something years, and I've seen this back and forth. So the teaching or the practice kind of principle in our clinics has always been like a middle lane, if you will. We're not opioid-phobic. At the same time, we're not very enthusiastic in terms of using opioids as the primary kind of analgesic. And, but to me, it's basically, I typically divided these patients into two different categories. So those patients that have kind of failed non-opioid therapy, and you want to start an opioid, and you probably want to titrate it to the effect. But the second group of patients, you probably, all of you have seen these patients. They are on very high dose opioids. They still complain a lot of pain. And these are the patients, I think, opioid-induced hyperalgesia as a concept, or as the next kind of, as the assessment and as the kind of action you want to take to adjust these patients' pain treatment protocols. I think opioid-induced hyperalgesia should be considered. And so this, we really don't have much to talk about in terms of counteracting opioid-induced hyperalgesia. And I think not to put these patients into an opioid-dependent kind of state, and not to overwhelmingly expose these patients with high-dose opioids probably is a good starting point. And I have seen over years patients coming in taking combined more than 4 grams of morphine equivalent. And they have a fentanyl patch, they have an intrathecal, they have an oral dilaudid, 10 milligram at a time every 2 hours. So I don't know how they got it, but obviously there are willing physicians doing that. And so these patients, they are typically not doing very well. They are really different group of patients in a way. So I hope this as the introduction, so the next 2 speakers can get into why opioid sparing, if you will, opioid sparing methods will be useful in the perioperative period. Thank you very much.